So our final speaker is Dr. Helen Whiplash. She's an intensivist and consultant anaesthetist with a specialist interest in head and neck. So we're going to find out a little bit about Thrive.
Thank you. I thought it was doing it. Sorry. I thought you'd done it. Okay, so I'm not an obstetric anaesthetist. I haven't done, well, I do make probably about 2 or 3 trips a year to labour ward to usually rescue, retrieve patients to intensive care, or occasionally go and help with the odd difficult airway case. I just out of interest wanted to know, with Thrive, how many people in the room as a consultant regularly use Thrive and are confident using Thrive? So we've got 3. How many? 3 and a half. How many trainees are confident using Thrive and would be happy to do a Thrive case on their own? 1. Okay. So Mary and me were just having a discussion about the in Leicester, Thrive is very much everyone is using it. Whereas in Yorkshire, I think we were somewhat behind on this case. I do use it quite a bit as well, so I enjoy it. As some of this lecture, something amazing authorised, I have borrowed from Justin McKinley's, who was probably one of the major people pushing Thrive in Yorkshire, and he got me doing it. So Justin and we all run a Yorkshire Difficult Airway course, which the next one, if I plug, is the 4th of November. So if anyone would like to come to it, we'll have Heather and myself and Stephanie all teaching it, and quite a few, and Matt Clark and various other people. So that basically looking at, as we know, difficult airway conditions, as Mary's point, there's multiple factors, and when we're looking at patients on easy intubations, things that can cause, and this is not just for just obstetric, any patient. Okay, I'll just keep talking. The mouth opening, next, which we've seen the triple felt, which I've actually had one of those patients before, which is really, in fact, it was a very challenging patient, and I did a weight fibre optic on that patient. Ended up doing her 3 times because she ended up in ICU. And then you've got to think, so when you think about, we're looking at patients, are they easy to intubate? You can't see any of my slides, so I don't know, easy to ventilate, what's aspirate and front of neck. So what I'm going to go on to, and you're always, again, thinking about your plans and your rescues. What is Thrive? Thrive is high flow nasal oxygen. It achieves, I don't know if it's through soft cannulas, which there's 3 sizes, and you can achieve up to an FI2 of about 1 litre, about 100%, just close. And we're looking at ranges of up to 40 litres a minute. For every 10 litres you go up, you get up a peak of about 1 centimetre of water, okay? And which is our alveolar recruitment. What we mainly is using it for apneic oxygenation if you've got a patent airway.
Sorry.
I keep talking!
Do you want to pause? Because I don't know why that's died.
Yeah.
I've got it on my review, but it's not going through the projector.
Do the motors change pitch? Might have killed the projector.
What you do, with the high flow of oxygen going in, you get CO2 water, reduced anatomical dead space, and reduced work of breathing. So this is, and it's all come about. So where the evidence from Thrive is using, a lot of it initially came from ICU. I've been using, as an intensivist, we've been using high flow nasal oxygen for many years. I can't actually remember how long we've had it on intensive care, but I know the work from came from basically from about 2014, 15 is where we're using. We're using it for, they've been using high-risk patients for in obstetrics, some in obstetrics, which we seem to be a bit behind in Yorkshire on. We have used it. Bariatric patients, I've used it quite a lot on acute patients for intubation, with a prolonged intubation, and an ICU for intubating patients. What I also love using it for is for awake fibre optic intubations, because it actually splints the cords open slightly, so you find that patients who are mainly moving the cords, you still get an aperture to go through, and it's brilliant for that. And I do some with ENT surgeries, apneic oxygenation in laryngeal surgery, where that's a surgery without using any tube at all. There's also showing now we're using it post-op for gastric for abdominal cardiac surgery. We've just now got it in our trust for recovery to try and reduce admission to ICU. We're just getting a robot, sort of a plug with which Sarah will be spending many hours with robotic surgery, so we've just managed to get it through for that. And in ICU, it's been shown to prevent reintubation if we extubate patients onto it. It's also now working its way into bronchoscopy, and Suzanne, one of just used it for doing for PEGs. It's very good for the patients who've got as neurological condition, progressive neurological conditions, where you're very cagey about what anaesthetic you want to do. Thrive with a bit of sedation is brilliant. So where does it all come from? Thrive, initially all the work was when I remember going to, I'm trying to which meeting I was at, I think it might have been Dublin. I first probably heard about it before then, with one of the World Aero meetings, or the last meeting is Patel, and another big talking about it, Neil Patel, and Alistair McNally, one of the Edinburgh consultants, is a massive fan, and they've been selling it to us all. We've got the high flow, it's humidified, I've got a picture of the kit, and it extends the apnea time significantly up to 13 minutes. What you do find, for every minute you get 0.1 kilopascals of CO2 rise, and they've done quite a lot of studies on this. So but the main thing is it's the oxygenation. You get these prolonged periods of time of quite happily up to 20 minutes in most patients, even in morbid. In 30 minutes in normal patients, in morbidly obese patients, they say about 19 minutes in a period of oxygenation to give you time to intubate that patient. Their initial papers, which many of you probably seen as a read, but it's still quite important, is they did it on the 20 patients. It's mainly on laryngeal surgery patient, pre-oxygenating, using the 17 with a 10-minute pre-oxygen, which I think is crucial. The 10 minutes, when you look at the obstetric papers that have come through recently, or they haven't done as long of pre-oxygenating, all the for various different operations, and when you look at this, all of them except for 23 to 25 had airways secured uneventfully. There was only a couple of patients who still had their apneas were slightly shorter. But if you look at the times in them, they're actually still longer than what you'd be getting normally in an anaesthetic, normally with bag and mask. And the mean time of apnea is 17 minutes. So the first few times I've used it, I was twitchy. It is quite twitchy the first few times to use it, but then you get quite comfortable with it. What it is, the main thing is it's a prolongation of the apnea time. So that's what is giving us time of oxygenation, so it's putting the volume of oxygen into lungs, how much, so things to make, how much can you start with, so it's making sure you get it on early to the patient, having them sitting up right, not lying flat, and all the things that you do anyway for obstetric. And so you get this prolonged time of apnea oxygenation. The studies have been done on, I've seen there was some studies done in Nottingham where they have got on simulations of pregnant people where they get a model simulation of the length of time, significant apnea times of oxygenation. And Mary's was telling me, for her experience, they're routinely using it now in Leicester in a lot of GA sections. One thing is you have to be worried about is the consumption, which, having read some of the papers in obstet, you do have to worry. I don't know if we found a paper that where it's different if you're not in labour to be actively in labour, how much difference in apnea time. And you do notice that if you've got a large FRS body weight ratio, the ratio is low, apnea time is slightly shorter, which is what we'd expect with morbidly obese patients. So this is what carbon dioxide, and it just shows over the time, a gradual increase of CO2 going up. But even still, so I've done, the longest case I've done, ENT case of a tube is about 45 minutes. And that was, I only do simple cord stuff. We haven't done extensive stuff that we can do, adjustment we've been doing in these. But I find that the CO2 has been fine, and I think the lowest saturations I've had is about 94 on a long case. I've had one lower saturation on induction, but that was me actually supervising another consultant who I was really wanted to shove out of the way because it actually weren't holding the airway properly, and that's a crucial thing. So, okay, there's a lot of physics and about how getting rid of the CO2, which is way beyond my 30 minutes. I spent about Fisher Packle did a care conference that I went to last year, and just we had about 2 hours on the physics of how they get rid of the CO2 in all the models. But it is through supraglottic vortices and cardiac oscillations is now the latest proposal of how you get rid of the CO2 goes. So and there's a nice paper now in Anaesthesia if you'd like to read up about it, because it's very good. So this is the kit base that generally most of us are on the Optiflow. Armstrong do it. There's 2 companies in the UK that do it. There's Fisher Packle and the Armstrong kit. It's very simple. This is the old kit. There's a new kit that's upstairs. There's the latest model. So you have a nasal cannula bit on the end that is single use to patients. You have the machine, which is with nothing on it, and then this is the circuits you add in. It takes about a minute to set it up. It does need plugged in, and it needs a bit of water. You put about water in there, and then needs warmed up for it to use. And crucially, you need a splitter for the anaesthetic machine if you're going to use it, because you need to split the oxygen at the back. So you need to be able to, if you're going to do total thrive as an ENT case, you have to put the patient to sleep, which is most from obstetric, from my obstetric GAs, I presume most GAs are put off to sleep in theatre. So you need a splitter on the back of the machine, so you've got your circuit there as well. So that's the crucial bit of the kit, and you need an ODP who knows what they're doing as well, But it's really simple to train people how to set it up. If you're going to thrive, this is one of the Alston narrows. If you've got to thrive for a purpose, you do have to play a bit of it on a note. I played with a few inductions on sort of my max facts list just to practice induction before I actually wanted to do. But you must to get happy doing it on a normal slim patient and then build your way up onto fatter patients. Because just to get your hands the first few times, it is a bit twitchy. The machine needs to be warmed up, and you need to have a team brief. If I've been doing total thrive, you do the team brief for the whole case before you put the patient off it. You need a bit more sleep. You put the patient off to sleep, and then you must maintain the airway at all times. That's the most important thing. Until you either get a tube in the patient, or you're doing the whole, which would be for obstetrics, you must maintain the airway. Some of the things picked up on from the papers I've been reading as obstetrics is whether or not you need to keep your mouth shut. Because they limit the entrainment of air, so you must have the mouth shut. Okay. And then you will give the muscle relaxant, you wait for your muscle relaxant to work, which is the first few times it's a bit twitchy, and then you put your tube in. But it gives you that confidence. I've let some very junior trainees intubate quite morbidly these patients, because I know you can give them the time when they're calm and they're relaxed, and they usually get it first time, because it's nice and calm and relaxed. But it does fail. This is what I've seen it airway, mainly not airway, not painted, and sometimes people just not arm. Because the majority of anaesthetists nowadays do a spinal or an LMA. Not many people, unless you're doing head and neck the whole time, actually maintain airways for long enough to put for the muscle relax. So you've got to be good at keep the airway open, patent. Occasionally people with big floppy epiglottises, high BMIs. They say I've done some pretty big people with Thrive, and actually most of them have maintained, their SATs have been the best on Thrive. Then you put the tube in and the SATs have been lower. Once you've got them into theatre, they can be quite difficult to ventilate. And then pre-existing lung disease. Some of these patients, I've not as yet done any horrendous lungs, but an ICU we use it the whole time, and I've not had any issues with it. But these are the ones that potentially could fail. So Thrive in obstetrics that I found, I've had a lightning strike this week, so my internet's been off all weekend. Got it back last night. So I was searching. Obstetric Association, this is done by Neil Patel and Dr. Whiteman from UCL, and it was recommending that Thrive is the way forward for all sections, GA sections. I think it is really good, but you've got to be careful with it. It does give you this prolonged period of apnea time to get your tube in. But there's got to be caution. They did a study here. There's a couple of studies that have just been published, one in the BGA and another one in Anaesthesia. This one was one from this is the Australian study, and they had, how many patients was it? I think 80s, is it 90s? In the 90s of patients. They were looking at where standard you'd give you 3 minutes of pre-oxygenation, expecting to get your oxygen levels up to 90%. they were looking at achieving this with high flow nasal. They weren't doing what the standard technique I would do for if I'm using it in head and neck surgery, where they were giving them 30 litres of flow for 30 seconds and then pushing up to 50 litres. I generally most of us are cranking it up to 70 litres right from the start. So as soon as a patient hits the anaesthetic room and I'm doing a Thrive anaesthetic, even if it's just for induction to put the tube in, I turn the oxygen up high. This study didn't do that, and they were also, the mouth wasn't shut. So they had, I've got it written down here, it was quite significant numbers, it was 73 patients. Things I noticed that the flow was too low and the mouth opening, they hadn't got the mouth opening. They did comment on a lot of the things about the physiological changes of pregnancy and why they showed that oxygen levels. So at the end of the 3 minutes, they then took them off and put them onto a face mask to then measure the end-tidal oxygen concentrations. So, and they were comparing this to just face mask pre-oxygenation. And from this, they concluded that they'd reduced, but actually, when you're looking at it, they weren't using Thrive as most of us would as most of us would be using it regularly would do. So they weren't giving enough oxygen. And they also comment that with the BMIs, the oxygen amounts were going down. But on a positive note, they said that everyone was very comfortable with it. But I think their study is slightly flawed because they weren't commenting. They weren't using Thrive as we would normally use it. A lot of us are used to using it. And then there's another one that's just come out in anaesthesia in April, and it is very similar again. And they're doing similar. Their flow rates were slightly higher, but they were still taking it off. And what they're not is, it's not the end tidal at the time we're about to intubate. It's how long the oxygenation period you're getting is the really important thing. The fact that we know from all the Patel studies and all the other studies that you're getting up to 20 minutes. Usually in morbidly obese patients of apnea oxygenation per time, and that is giving you a really long time to get the tube in. So I've got a case that I borrowed from Justin that I've not used Thrive in obstetrics yet. So it's not, but we've got a few. But and they used it in a known subglottic stenosis patient. It was a patient. So some of you leads know about this, probably know more about this case than I do. Justin's told me about it a few times. She was next prem, did laryngeal surgery and reconstruction. Her first pregnancy, she had a stridor and had done under section, emergency section. She didn't want any tracheal dilatations during pregnancy because her symptoms went away. Then she got pregnant again and then came back and she had a CT which showed a stenosis and she was getting stridor. That was the nasal endoscopy, just showing the stricture down there. And she was planned delivery at 36 weeks due to worsening symptoms. We had a very good discussion about how to do about plan A, B, and the decision was to use the high flow nasal oxygen to get the extra peak recruitment and do CSE. And then the plan B was to intubate, knowing that they would only be able to get probably you might even struggle to get a microangle to be tubed down through that stricture. But they were worried about the risk, so we decided to go for the section. They did a CSE, which all with the high flow nasal to supplement oxygenation, and it all went very well. It's uneventful, and then her symptoms were significantly better after after the baby was delivered, which was unsurprising. However, which has then been published. I had a similar case with Sarah. We don't have this. This girl still gives me nightmares about 8 years ago, and this was slightly difficult. Is high for Thrive for all subglottic stenosis? No. This was a prolonged subglottic stenosis. This is a young Asian girl who was 27 who presented at. Well, I first knew about it the 2 days before her section, when the obstetrician said, "You laugh at this, you don't need an airway to have a baby," was the comment we got. As well as the ENT surgeon, Vicky Ward, is a good friend of mine, came into my theatre going, "Helen, I need your help." They thought that she was vague nurse. She had stopped taking her, she'd had this stricture pregnancy. She'd DNA'd things, ENT and I think the obstetric team looking after her had sort of not realised how important this airway issue was going to be early on. Later, so then at 36 weeks pregnant, we then got this, we could get one x-ray, she was too pregnant to go in the CT scanner. So we then...
She couldn't lie flat.
She couldn't lie flat. So we had a plan, Sarah, me and Vicky Ward and the other chatted, and we went, okay, Thrive at this point wasn't on the go, and I still don't think I would Thrive her. I wouldn't do. So I think you've got to think about, if you're going to Thrive, what is your backup plan and what is your other airway? This girl has a long lesion. When I put her off to sleep, all I could actually get through the lesion was an atrial intubation catheter, which I squeezed down through the lesion. She then baby was delivered and she had a tracheostomy because her stridor was so significant post, and unfortunately during the whole process, a couple of days later, the trachea fell out. She still had sniffing trachea. I happened to still be there. I was on call again on ICU, and we got the trachea back in, but she couldn't cope without the trachea. That's her significant pressure. And when Sarah was putting the epidural in, she bent over and she desaturated to about 82.
I didn't put the TUI in the lungs, honestly.
No, so I still have nightmares because during the whole process of this block, the lesion blocked, and while they put the trachea in, and we had PA arrest for a period of time. But she woke up fine, and she then started taking her appropriate medicine and she's actually now not got a trachea anymore. But so it's not suitable for everyone. So just because I haven't even leaked that case, thinking, would I do it differently? No, I wouldn't. I think you've got to be, it's small lesions. It's good if you're doing CSE supporting or for induction of labour. So I think there definitely has a role to play. I think training is going to be a massive issue because looking around the room, how many was it? There was hardly anyone. 4 or 5 people said they were happy using Thrive. So I think you need to learn to use it on non-obstetric patients first with someone who's happy doing it in there, and come to a head and neck anaesthetist, get them to show you how to use Thrive, then go and try and do it, and we will happily come to, if you say you've got an elective section, are you doing a GA and you want to use it for your first time, I'm sure we'll come and help just if you're worried or to pair up and do that. It won't work for everyone, and I think they still need to worry about, from the protocols from these studies that I looked at, the time is not, 3 minutes isn't long enough. You need to give longer. I think you need to give longer. Mary's saying they're using it now on virtually during the day on all GA sections, out of hours depending on who's there, if the ODP's doing. It doesn't take long to set up. It does take a minute or so. But while you're getting ready for your emergency section, you can't leave it not set up because it's got to be sterile. The system only lasts for 24 hours. And you've got to put water in it and heat it up, but it does heat up literally within a minute or so. So as soon as they know there's a GA section coming, they switch it on. The note costs about £30 to £50 per go. But I think for larger patients, if you do the actual 2 sections, it's probably very good to do, and you just need to. But you need to be happy using it, and you need to come and use it with someone else first. I wouldn't play with it to start with when you're out, because there's a few tips. It is mainly holding the airway, and it's quite surprising how poor some people are at holding airways when you don't do head and neck lifts the whole time. Any questions?
Thank you very much for that. Any questions from the floor regarding Thrive? Yes, Dr. Barton.
It's just a comment really, that I have used it, and just a hint for people, the way I organised it was I asked Outreach to come and set it up because they're very familiar with it, and so one of the Outreach nurses came and was in theatre, and so that's something you can do if there's some case that you really think needs it. But I would absolutely echo that really we should be learning how to use it and getting more machines. So most ITUs have something like this, I would think. We do. We have nothing in York.
Any other questions at all?
Sorry, this is a follow-on from Amanda's point. We were a colleague of mine and I were at DAS in November. We both do airway cyclists, and we were doing the kind of round of lagging reps. And it turns out that they've created two systems, one which will deliver 100% oxygen, which is suitable for Thrive, and then the other one which will deliver up to 90% oxygen, which is what's used on the ward.
Yeah, that's we've got that. We just bought that for recovery because you do need that for afterwards.
So my question was, when you're trying to persuade your clinical director that the capital outlay is worth it, he's just come back to us and said, well, why can't you just use 90% oxygen? Is it really going to make that difference? Have you tried it with using the ward-based techniques, ward-based gadgets?
It's more expensive for starters. The ward-based ones are, having just done a business case for them, they're 2,500 and the consumables are more expensive. The one just for total is cheaper and the consumables are cheaper. And it's a bit more fiddly to set up and there's more buttons. This one is just you plug and you go. It's a lot quicker and safer.
Yeah, see, that was my impression. That it seems quite cunning on behalf of the manufacturers to not have cross.
You've got the directors behind you.
Can I just quickly take the lead on that one?
Yeah, sure.
Sorry.
It's a red.
So the reason for all the reason for the two devices is in the theatre setting you need 100% for the pre-oxygenation, because without it you don't get total denitrogenation of the lungs and you can't get the extended apnea times. In recovery you don't want to be giving 100% because we don't want to be giving 100% to patients in recovery, so there is that need for the two systems.
But you can't. That means that you can't use the same system.
You can use bits of it, but you need two different kits.
So the patient interface, it's a bit with the filter on. If you've used that in theatre with Thrive, you can keep that same interface and take that through to recovery. You do need to open up a new consumable set because they're different systems, so it's like different components.
But Chloe, it depends. If your recovery's got air in it, you will be able to use the ones you will have the nasal high flow from ICU. Our problem in our trust is that our recovery doesn't have piped air, so we've had to buy the air route 2, which just runs on 100% oxygen. That's a big debate. If you've got air in your recovery, you can use the ICU one in recovery.
Right, thank you very much.
So